All right, welcome back everyone to another mini lecture. Today we're going to be checking out the immune system, and then at the end we'll do a little bit of review on the integumentary system as well. So we're going to be starting off with shock. There are multiple different kinds of shock. Shock has different stages. So initially we're going to see the patient's heart rate increase, and then we're going to see a little bit of decreased perfusion to tissues in the body. Then your body's going to move into the compensatory stage. And this is when your body decides, okay, something's wrong. How am I going to reroute to make sure that we're still functioning as well as we can? So for this, you're going to see perfusion that is decreased to non-essential organs. So all of our essential organs, like our heart and our lungs, are still going to be getting adequate blood flow, but we're going to see that kind of decrease for not quite as essential organs. In the progressive phase of shock, we're going to see hypoxia or low oxygen levels in our organs. The patient's heart rate's going to be really high. Their lactate levels will come back pretty high. And then we'll also see decreased blood pressure and oxygenation. And then finally, in the refractory period, we're going to see tissue death. They're going to have decreased level of consciousness. They might have dysrhythmias. And then they might also present symptoms of MODS, which we will talk about later on. So one type of shock that we're going to talk about is cardiogenic shock. Cardiogenic shock, we have an unhealthy heart. So the heart itself is failing. And because the heart is failing, we're going to have decreased cardiac output and decreased MAP. A lot of the times this can be caused by dysrhythmias, or you might see this if a patient has a myocardial infarction and their heart muscle is damaged. Patients with cardiogenic shock are going to have tachycardia. They might have hypotension or a low blood pressure, pulmonary congestion. So they might have like some dyspnea. They might have decreased urine output. And then you might also see increased preload of the heart. Kind of the opposite of cardiogenic shock is going to be obstructive shock. In obstructive, I cannot talk today. In obstructive shock, the heart itself is okay, but something else is going on in the body that's making it fail at its ability to pump. So this could be due to stenosis, there could be aortic dissection, pericarditis, pulmonary embolisms, hypertension, the patient could have a pneumothorax, or we might see inferior vena cava syndrome. Another type of shock is hypovolemic. And so this is when the body is going to have low levels of fluid and we're going to see decreased perfusion and MAP. And this could be due to trauma, illness, or just other chronic health issues. Patients with hypovolemic shock are going to have a really quick but thready pulse. They're going to have decreased oxygen stats and decreased urine output. Their skin might be really pale and we might see some mottling. They could be really thirsty. They could have altered levels or decreased levels of consciousness. And then we're also going to see increased potassium levels and increased lactate levels as far as labs go. To treat hypovolemic shock, we're going to be giving our patients oxygen. We might also give them crystalloid solutions like normal saline or lactated ringers. We might start a central line on our patients to give meds, and we're going to be assessing vital signs every 15 minutes, as well as cardiac monitoring. In hypovolemic shock, we can give vasoconstrictors such as norepinephrine and dopamine, and then we might also use positive inotropes like epinephrine and dobutamine. In septic shock, our patient is going to have sepsis and hypotension despite fluids being given. You're typically going to see a lactate level over 2 millimoles per liter, and we are going to make sure that we're screening for sepsis roughly every 8 hours or once a shift, and we're going to be using vasopressors. The care for septic shock revolves around the 1 hour bundle. And what this means is we're going to start off by drawing some lactate levels on our patient. We're going to do blood cultures, typically within 45 minutes. Then once we do cultures, we'll get them started on an antibiotic. Do not give an antibiotic before you get cultures drawn. And then we're going to move on and give 30 mils per kilogram of body weight of a crystalloid solution, as well as give the patient vasopressors. For septic shock, we have 2 tools that we can use for screening. Muse is going to be used to recognize that sepsis is occurring. And then QSOFA is going to recognize patients at high risk for sepsis and then also kind of tell us how likely they are to have poor outcomes from sepsis. So SIRS is going to be a term that we use to describe increased levels of inflammation, and this is due to bacteria that is in the blood. Patients with SIRS are going to have a fever. Their heart rate's typically over 90, and they're typically going to have a respiratory rate over 20. In MODS, we're going to have organ damage, and this is due to toxic metabolites or toxic enzymes that have built up in the blood. So different immune disorders. First up, we have lupus. So lupus is an autoimmune disorder. I commonly associate this with Selena Gomez. Patients with lupus might have like a butterfly rash that goes across their nose, kind of like a bridge. They might get coin-shaped lesions, oral ulcers. They might have photosensitivity, which is when they go out into the sun, they're going to burn and have a really poor reaction. Osteoporosis, nephritis, which is inflammation of the kidney, and then also pericarditis. For lupus, we want to make sure we're giving our patients NSAIDs. They might get some aspirin, corticosteroids to kind of help out, and then they might also get belimumab. Something else that you're going to see given with lupus is anti-malarial medications such as hydroxychloroquine. And we really want to make sure that when patients are taking this medication, they are getting frequent eye exams because this one is pretty damaging to the eyes. When we have a patient with lupus, we want to educate them to avoid exposure to the sun. Stress and pregnancy can also cause flare-ups of lupus. So we want to try to avoid stress and sun exposure as much as possible. Next up, we have gout. So in gout, a patient is going to have high levels of uric acid build up in their body. This is usually caused by purine and fatty acids, and this is going to reside in like alcohols and meats. Risk for gout is going to increase with age. It's also more commonly seen in males, and then patients who use thiazide diuretics, such as hydrochlorothiazide, are going to be at an increased risk for gout as well. Symptoms of gout may include gouty arthritis. We might have tophi or these crystals. We might have stones in the GI tract, and we might also see hyperuricemia, which is that high acid levels. We want patients with gout to decrease their consumption of red and organ meats, alcohol, and shellfish, because these are foods that are very high in purine. And then as far as treating gout, for acute flare-ups, we're going to use colchicine. And then for maintenance gout medications, we're using allopurinol. Next up, we have HIV. So the cycle of HIV begins with attachment. Then we have fusion, reverse transcription, integration, transcription and translation, assembly, and budding. Stage 1 HIV is typically the first 4 weeks, and here patients are going to have a very high viral load, so it's super likely that they're going to transmit this disease to someone else. In stage 2, this is where we're typically going to see drug therapy starting. Patients will be tested for their viral load and their CD4 cell count. And then stage 3 HIV is when we officially get that diagnosis of AIDS. People with AIDS have to have a CD4 count under 200, or they have to have opportunistic infections. Testing for AIDS is going to be more accurate once our patient has reached longer than 3 weeks from the time that they were exposed. And testing, we're typically using a chemiluminescent and Western blot test. When patients have AIDS, we're going to be monitoring their lactate levels, their red blood cells, and we're going to be doing liver function tests. And to treat, we're going to give oxygen therapy when necessary, and then also use HAART or highly active antiretroviral treatment. Allergies. So allergies can be diagnosed through looking at IgE levels, complete blood cell counts, or through skin tests, which is when they'll put a little bit of an allergen onto the skin and then kind of come back and see how your body reacts. When people have allergies, we're going to treat them with epinephrine. So this would be like your EpiPen. We might use histamine medications, oxygen, and then we might also get fluids. And when patients have an allergy, I'm sure you've seen in the hospital, but they'll wear like a little bracelet that says that they're allergic to something. Moving on to the integumentary system. So we're going to be starting off with burns. And something that you'll commonly see with burns is the rule of 9s. So the rule of nines is just a way to help remember kind of what percent of the body's been burned. So we typically attribute 9% for each side of each arm, 9% for the head, 18% for each leg, and then 36% for the chest or kind of like your torso. When trying to figure out how much fluids we should use for patients who have experienced burns, we're going to be using Parkland's formula. And for Parkland's formula, we're going to take 4 milliliters times the patient's body weight in kilograms times the percent or surface area of the body that has been burnt. And when we do that math, it'll give us the amount of fluids that we should be giving to our patient within 24 hours. When we get that number, we're going to take it and divide it by 2, and then that is the amount of fluid that we are going to give in the first 8 hours. We will give the remaining half of the fluids in the last bit of the 24 hours. When patients have burns, it's important to encourage range of motion. We're going to put them on cardiac monitoring, give oxygen. We want access to a large bore IV, and then we'll also administer morphine, Tylenol, gabapentin, just things to help kind of manage that pain. We'll also do a BMP and lactate level test. We want to monitor the patient's vital signs frequently, voice quality, lung sounds, urine output. We're typically aiming to do this once every hour. And then we also just want to monitor these patients for Stevens-Johnson syndrome, which is a very big systemic rash. They might have conjunctivitis or mucositis. So superficial burns, we have first degree, which are red and pink, typically very painful, and they'll heal in about a week. Second degree superficial are going to be red, moist, and then you're also going to see blistering. And these ones take a little longer to heal, usually within 7 to 14 days. For second degree deep burns, these are going to actually be less painful. They're going to be moist and the skin is going to be blanchable. Second degree burns might need a graft, but not always. In a third degree deep burn, the patient will not have any pain. Their burn could be, or their skin could be any color. It'll be dry, not moist. And these patients do need a graft to help heal their skin. And a fourth degree deep burn is going to be black. They're going to have no pain, and we do need to focus on specialized cares with these patients. Fourth degree burns aren't always going to heal. Pressure injuries. So stage 1 pressure injury. The skin is going to be blanchable and red, but the skin will be intact. In stage 2, you're going to see partial thickness. Stage 3 is going to be full thickness. And then in stage 4, you're going to be able to see their bone, their tendons. You might see tunneling of the wound. Patients are at a higher risk for this when they score less than 11 on the Braden scale. And when we have pressure injuries, wound healing is super important. Some stages of wound healing are re-epithelialization, which is when the basal layer of your skin is going to produce new skin cells. Granulation, which is removing damaged tissue from the wounds. And then contraction is when your fibroblasts are going to pull the edges of the wound inward to help facilitate healing. So that is all we have for today's mini lecture on the immune system and integumentary system. Stay tuned for the next video.